I'm Doug Katzev. I've been in practice in Santa Barbara, California for 35 years.
Mm.
I did my cornea fellowship at UCLA before coming up, and I've been very involved with C International, where we go abroad to help out the underprivileged in those countries, as well as my private practice here in Santa Barbara.
Where did you get the curiosity around the technology with eyes? I'm guessing as a medical doctor, you're interested in the body and science, but technology snuck in there as well. When did that start for you?
Yeah, very early in my career, I was with some innovators at Emory, and we
Mm.
did some new things in corneal transplants and got involved there. Then I went back to St. Louis, where I'm from, and started there. In search for a new chairman, I was determined to help the president of our university get somebody that's progressive. And I got him to get David Shanslin, that was at USC, who was really involved in the new way of removing cataracts, and that was called phacoemulsification. Before that time, we were opening the wound very wide, having to suture the eye back up and create all kinds of astigmatism and a long recovery period. And then with this very small incision, we go and remove the cataract, slide a lens that goes in like a burrito, unfolds in the eye, and there's no sutures needed, recoveries a day. And that really intrigued me. I was also involved with RK early on, and then realized LASIK could make it quicker, better,
Mm.
faster
Mm.
rehab. So all these things I brought to market, some in residency, but a lot in private practice.
And I'm guessing you've had your finger in technology. One of the things about TED, the T stands for technology, and the D stands for design. And I'm curious what the role of design has been as it relates to eye care.
It's kind of interesting, but you think of academics as producing most of the things and new projects, but in ophthalmology, it's the guys that are doing a lot that come up with new ideas and try different things. In fact, intraocular lenses were poo-pooed by our most of the academic centers. And it was more the guys in private practice that brought lenses in, and it turned out to be the best thing that we ever did. Same
Mm.
thing for refractive surgery, not liked at the academic centers, but guys in private practice would go over to Russia and find out different things and come up with different things. We had our own meetings. I go to a lot of meetings, at least 6 to 7 every year, where I'm one of the big presenters at the meetings. You go to present on something, but you learn as you're presenting. You're with
Right,
all your peers, and that's the way you really
right,
progress.
right. I love that part of peer-reviewed work. And our listeners know we founded Wavefront here in Santa Barbara, and I loved going to the shows and talking and specifically trying to hire away the people who wrote the most interesting papers. And so we could give them jobs and fly them here to Santa Barbara. I love that.
I
I'm
just got back from Tampa, Florida, teaching all the third and fourth year residents that are coming out of their residency program how to do cataract surgery. And one thing that we all convey to them is, in academics, they sometimes say, be careful of the industry people. They're going to lead you the wrong way. And we tried to say, you got to be friends with industry because you're going to progress together. Without industry, you're not going to have the next greatest machine to do the best, least invasive procedure.
right. And just stay with that least invasive procedure. The way I understand it over the last, it's probably 20 years, and then in the last 10 and 5, you've been able to go out to these rural villages all over the world and rural towns where they just don't have the money and be able to do these cataract surgeries at an astounding number a day because you've perfected the speed and ease at which you can do that. Why don't you tell us a little bit about that?
Yeah, when we go to a third world country, we're not removing the standard cataracts that I'm doing here in the United States, where I'm taking somebody that's just having trouble driving And so we're taking the cataract out, giving them a lens that's going to allow them to see distance and read without glasses. When I go to a third world country, I'm taking somebody's cataract out that's white. This
Mm,
person can't go to work. This person could never drive a car. This person has to be led around by his family. And so you're not only taking him out of the working world, you're taking a family member that has to feed him, show him where he's going, doing everything. And then in a 10-minute procedure, you can take the cataract out, put a new lens in, and all of a sudden they can get around and their life goes on. I always remember in Fiji, I was there and we're seeing a whole bunch of people pre-op figuring out which one we should do. And these three women came in. They were kind of close to each other. They all had teams. I remember that. And then we operated them. Three different surgeons operated on three different people. And they got up and they saw their sisters for the first time in like 10 years. It was really like, wow, I had no idea they were sisters. They were being introduced to their grandkids that they've never seen because they've only heard them. So, you see something like that and it's really special.
that I think that's where that 35,000 number comes from. And how do you go every year?
I try to go once a year. I try to pick somewhere unique. Uh, I've been all over India teaching them how to do new corneal transplants. That was incredibly enlightening to me. I went to Africa and took my whole family there.
Mm,
My son, who was a big baseball player, he was in school. He liked school somewhat. He decided he was not going to play baseball and become a doctor after being there and working with us. And it was a way that he wanted to do it. It's hard to be a doctor. It's a
yeah,
lot
it
of
is.
work. You
Yeah, it
give
is.
up a lot of time. You could be going out drinking, doing other things, and you have to put a lot of effort into it. And it's not easy to get into. You may have to wait a year to get in, especially the way things are today. But he determined that he wasn't going to play baseball. He was going to be a good student and have fun in college. And he did. He's in his third year of medical school at WashU in St. Louis.
I'm curious. So it was technological advances that allowed the cornea that you're putting in, right? And that's what you put in, to get
Uh,
to a price. What do you call that?
it's actually an intraocular lens.
Okay,
The
cool.
cornea is the front of the eye that does
Yeah.
most of the refractive. We treat LASIK and refractive procedures on the cornea, but the lens is actually something that's behind the iris, and it's in a
Right.
little bag that we take the inside of it out and then slide a sort of a taco looking unfolding in the eye that fits into this bag. And that's the new lens that corrects it so they can see without glasses.
So what was the breakthrough that allowed you to be able to do that at scale?
Well, many different breakthroughs, but there's a guy named Charles Kellman that was a very good musician, pianist, that had this idea. He was a retina surgeon. He had this idea if we could get it through a small incision, that we could do it much better. Well, that required breaking up the lens into little pieces. Before, they would make an incision in the eye, push on the eye, and the lens would pop out. Um, but
Oh, sure.
in that period, you have to protect the cornea and different things. So it took a lot of innovation to improve that. Charles Kellman was an inventor, a really good guy, not the best surgeon, but he had lots of people with him that improved what he did. And at all our meetings every year, I go wondering what I'm going to figure out that's going to make my life easier. And it's just one little thing after another that you keep adding to it that makes it so that I can do 20 cataracts in a morning and the next day everybody's seeing well. That's a fun day.
That's just amazing the impact you have on entire families. I'm curious, is there a an eye situation now that people are working on that will have a similar kind of impact?
They're certainly working on the retina in a big way with stem cells.
Oh,
Macular degeneration is a damaging thing to our elderly population. and something we can try to prevent with injections to stop the vessels from growing to destroying the rods and cones. But if we can somehow reproduce those rods and cones that are damaged so that you can people that we presently cannot improve their vision can get their vision back, that's a 20 years away, but
It's
that's
that
going to
long.
happen. Yes. I think it's 20 years away, but it could be sooner. I've seen it happen. I know it's going to happen, but there's a lot of hookups between the optic nerve and the rods and cones that have to be formed that we can't just go in there and surgically do. It's got to sort of somehow grow together, and we got to figure all that out. But I think we'll figure it out. More recently, corneal transplants were really common, and you had to take a cookie cutter and remove the cornea and replace it with a new cornea, and then suture it in with 24 sutures that could be tight in one area, loose in another. And so you had to take a long time for that to improve. Well, now we just take these little cells off the back of a cornea from a person that's passed away, and I go inside the eye, remove these corneas on the back of the person's cornea that I'm going to improve. I'll inject these cells that are in there in a disc form. I'll take a little air bubble and put it under these cells, and I'll prop it up against the present cornea. It can make corneal edema go away. That's happened in the last 20 years. I was in Portland, Oregon, and this guy, Mark Terry, comes up to me as I'm giving a lecture. He goes, I'm going to do this thing, and I'm going to replace these cells, and we're not going to have to do our big transplants anymore. I go, that's great. Let me know when you get it done. 10 years later, he got it, figured it out, and I'm doing it. And it keeps improving every week. I had somebody that came in today that had a multifocal lens in, but had this thing called Fuchs dystrophy that destroyed these cells on the inside of his cornea, and he had swelling. So he had a beautiful lens surgery, but he couldn't see because his cornea was swollen. About 3 years ago, I went in and removed those cells, floated these new cells in there, put them up there with just an air bubble, no sutures. And today he was 20/20 in both eyes. And I didn't think that was possible, but it certainly is now.
And that was 3 years from the procedure to your test, the 2020 test.
I did it 3 years ago. He was seeing within probably 2 months, but usually seeing within 2 months, we're 20, 25, 20, 30. He was 20/20 without anything and seeing distance near and everything, and something that we could not have corrected like that years ago. And and you can't hardly even see what I did. That's amazing to me. When I come in, I don't even realize I was in the eye, and I have to think back, and I'll look at my notes sometimes. Did I do this? It's pretty amazing.
What's a common misconception that you've got to correct for when people come in to see you?
Well, I think everybody wants to see without glasses if they can. And they have to understand that when the newer lenses that we put in, we have to have a good retina. We can't, if we got a bad retina, I can't really put one of these newer lenses in. We have to have a good cornea. If I got a bad cornea, it's hard to put one of these lenses in. And when you put the lens in, you will have a little bit of haloing because that's the reading part working when you're trying to see distance. Now that gets better, and they have to understand that. And I would say it's very unusual that a person doesn't really appreciate what we do with the end result. But they have to understand all those things. And as a surgeon, as a busy surgeon, lots of people, you have to convey that to them in a reasonable period of time so they can understand it, think about it. But we're busy right now. There's not enough ophthalmologists.
Why is that?
Yeah, when I graduated 35 years ago, 500 graduate every year to serve the United States. So there's a little fewer of us right now to do all the work. And then you got the millenniums that come out, and they're kind of interesting. When I came out, I was like, okay, where can I go and work really hard and see a lot of people and help a lot of people? And I would ask these questions, not how much I got paid. It's actually that wasn't important to me. But what I could do, how I could make a difference. They really well trained. They're really good people, but their first question is, how much vacation time do I have? And it's very different than us. And when I was doing my internship and residency, you worked all night shifts and then you
Yep,
worked the rest of the day.
that's
And
how it is.
you did lots of that. And now I hear these guys, if they work the night shift, they're off the next day. They have to be. And so there's a limited amount of call that they can take. So they're coming from a different perspective than what I came from.
When you when you go speak to these students, how do you kind of convey the importance of this job they've chosen, this role they've chosen in the world?
Most of them have really chosen this for the right reasons. I don't think people choose medicine for money because I think
Right.
you go to private equity if you want that. You go to some other things. If you choose medicine, they've chosen it for the right reason. They just also realize they want more than just work. Um, I've seen a balance here in Santa Barbara where I can work really hard and play really hard. But they want to make sure they're balancing their play, which I think is important. But they're all pretty good students that really want to learn. They're excited to be there. They want to hear what you have to say. They know we're like the pillars of the community that have done a lot. We're always on the podium, and so they're excited to meet with you. And it's a great group. Any ophthalmologist I interview, it's the hardest specialty after medical school to get into. So they're all pretty premier students, and so they're the cream of the crop, and they're always willing to listen. They're ready. They hang on each word. They try to figure it out, and the companies really put all the really good teachers together trying to help these kids because they want the same thing. A company that produces a machine to remove a cataract wants that cataract surgery to go well and their intraocular lens to go well because that produces more people coming and them making more money because more procedures are performed. So it works hand in hand that everybody wants to do the right thing.
Of you. Thank you.
Thank you.